Aortic stenosis is progressive disease which causes the obstruction in the left ventricular outflow. Most common symptoms of this disease is angina, dyspnea, and syncope. You can also associate with the mortality with these symptoms. The greatest mortality is associated with the heart failure. It is 2%. With the syncope, it is 3%. And with the angina, it is around 5%. What are the most common causes of the aortic stenosis? The most common cause is age-related calcification. Beside that, if in young patient, if patient coming less than 55 age, bicuspid aortic wall is most common. Bicuspid aortic wall is associated with the 50% aortic aneurysm. It is bicuspid aortic wall have also been associated with more common prevalence in the male as compared to female, 3:1 ratio. Other causes of aortic stenosis are rheumatic aortic stenosis, subvalvular aortic stenosis. The Sean syndrome is also sometimes have subvalvular aortic stenosis. What happens when there is aortic stenosis? First of all, if the aortic stenosis causing LVOT obstruction, there is increased gradient in the left ventricle. Increased gradient causing the increased afterload, which causes the stress on the walls of the left ventricle, causing diastolic dysfunction, inability to relax, and also causing myocardial oxygen supply and demand mismatch after there is diastolic dysfunction. Now, patient may be asymptomatic. If patient have asymptomatic, there may be mild, moderate, severe. If there is mild, uh, according to AHA guideline, you have to review the echo 3 to 5 yearly. If moderate, 1 to 2 years. If severe, 6 to 12 months. On clinical examination, you can find pulse is slow rising with narrow pulse pressure. Along with that, there is a carotid upstroke. Usually, carotid pulse is characterized by normal, normal smooth upstroke and more gradual downstroke. But in the aortic stenosis, there is slow upstroke and delayed systolic peak. This is usually called as parvostradus. Apex beat is usually not displaced until later stages, which causes the heart failure and which causes the apex peak to be displaced. S1 is usually normal, soft. A2, S2 can be paradoxically split because of prolonged ejection duration through severely narrowed aortic valve. S4 is common due to reduced compliance, LV compliance. You can hear the murmur, which is crescendo, decrescendo, ejection systolic murmur that radiate to the carotid. With a mobile bicuspid valve, aortic opening may give a sound of aortic click. On clinical examination, what you can see the aortic stenosis is severe or not. If following things are present, you can say there is severe aortic stenosis: inaudible A2, paradoxical splitting of the S2, late peaking murmur, and pulses Parvus. There are different maneuvers you can do to the patient to increase the intensity of the murmur. Hand grip and passive leg raise increasing the intensity of murmur as compared to in Hokum, it reduces the intensity of murmur. Now, according to AHA, the stages of classification, stage 1 is the rest, bicuspid aortic valve or aortic stenosis. B is progressive aortic stenosis and mild, which have aortic valve more than 1.5 and gradient pressure gradient less than 20 mm of mercury and jet velocity is 2 to 2.9. Asymptomatic stage C is asymptomatic severe AS. It has two types, C1 and C2. Both have severe AS while they are less than 1 cm, gradient more than 40 centimeters, and aortic jet velocity more than 40 meter per second. But C1 have normal EF and C2 have EF less than 50%. Now, stage 3 symptomatic severe AS have D1 stage, which have valve area less than 1 centimeter, greater more than 40, and jet velocity more than 40 milliseconds. Now, the D2 and D3 are both symptomatic, but D2 have symptomatic severe low flow, low gradient AS, and EF is also low. And D3 are symptomatic severe aortic stenosis with the low gradient, low flow, and normal EF. You can do a low dose dobutamine stress test, which causes the D3, which is paradoxical severe aortic stenosis, can improve the LVEF function. On investigation, you will find in the ECG left ventricular hypertrophy, left atrial abnormality like P pulmonale. In the X-ray, you can find cardiomegaly, aortic valve calcification. In transthoracic echo, you can find the severe thickened AS calcified aortic valve, subaortic stenosis, supravalvular AS. You can see the Mercedes-Benz sign, and you can calculate the transvalvular jet velocity by modified Bernoulli equation. Transesophageal echo, if you're not sure, not clinically sure about the aortic stenosis, you can do it. Exercise testing is contraindicated in the symptomatic patient, but asymptomatic patient you can proceed. Cardiac CT you have to do before it is normal workup for if patient is going tower or sour, and to see the anatomy and aortic valve and aorta. If patient is above 40, you can do also cardiac catheterization. Now, guideline according to AHA for the treatment of the aortic stenosis. If someone is symptomatic severe aortic stenosis, it is class 1 to treat it. If someone with the severe aortic stenosis, asymptomatic low EF, again it is class 1 to replace the valve either by transcatheter approach or by surgical route. If someone has severe AS, EF less than 50, but asymptomatic, then low EF you have to also replace the valve. A patient is asymptomatic, stage C with the EF less than 50%, again the class 1 indication to replace the valve. Or if patient is stage C, asymptomatic but going for the cardiac surgery, again class 1 to replace the valve.